All right, super. All right, we'll get going. Again, thank you for your patience. So my name is Dr. Emma Wilson-Lemoine. I'm going to be moderating your session today. So we've got an exciting topic lined up with some of our three wonderful speakers. So just before we begin, you might have been to some of these Ask an Expert sessions already, so you might be familiar with the setting, but the topic of this particular session is looking at digital mental health and scaling measurement-based care. So the sessions are designed to bring together three experts from different perspectives and backgrounds on an important topic in the field of digital mental health. So the way this session is going to be structured, it's very informal. So I'm just going to introduce our speakers today. I'll give each panelist a couple of moments just to kind of add anything that I think is important to sort of add a bit more context to their connection with the session topic. And I'd also ask if you could just highlight any conflicts of interest or relevant disclosures at this time. We'll then jump to audience questions. So for this, please just unmute yourselves, put your hand up, post in the chat, however you wish to participate. And then our session will end in about 45 minutes. Okay, so I'll get started. So first we've got Dr. Caitlin Shepherd, who is a licensed psychologist with over a decade of clinical and research experience in the mental health field, with a specialty in eating disorders. She is currently the clinical research director at Within Health, which is a fully remote eating disorder treatment program offering partial hospitalization and intensive outpatient services. In this role, she oversees the clinical research and outcomes program, including co-leading the company's measurement-based care initiative. Dr. Shepherd has extensive experience using data-driven approaches to supporting individuals with eating disorders and other mental health concerns across diverse settings. She has held faculty positions at multiple institutions and maintains an academic appointment as a research affiliate at Smith College. An active member of the Academy for Eating Disorders, she currently serves as co-chair of the Educational Programming Committee. So welcome. Next, we've got Dr. Marisa Perera, who is a senior manager on the Clinical Innovation and Research team at Two Chairs, which is a tech-enabled mental health platform focused on using technology to support personalized care. She leads initiatives to advance measurement-based care, developing scalable, high-quality systems that empower clinicians to improve the therapy experience for clients. Dr. Perera has designed measurement-based care frameworks for academic medical clinics and is also the founder of Natal Counseling, a boutique practice dedicated to providing tech-enhanced mental health support for individuals navigating fertility, pregnancy, and postpartum challenges. So welcome, Dr. Perera. And finally, we've got Dr. Simon Weisz, who is the president at Greenspace Health, which is a technology company focused on measurement-based care. Greenspace has supported more than 500 implementations of measurement-based care across a wide range of organizations, populations, and levels of care. Simon participates in advocacy and education on this topic, including as a member of the APA Committee for Measurement-Based Care, and completed his education in law and business, and also serves as chair of a national charity targeting homelessness prevention. So welcome to all the speakers. Thank you so much for taking the time today to discuss this important topic. I'm just going to go around and just ask if there was anything else you wanted to introduce relating to your background and whether you have any conflicts of interest. So I'll start with Dr. Shepherd, if you could just, go ahead.
Yes, thank you. So yes, I am an employee of Within Health and also hold stock options there, but have no other disclosure.
There's more break stuff I need to do. Like I'm like, I've written the work, but I just like take some time to understand it.
There we go. And I honestly couldn't remember what was said in my bio, but I think I covered it pretty well there. But I will just add that I've been at Within for about 3 years, and I'm really, excited to be here today to talk about this topic, especially our program has scaled and grown so much during that time. Our patient census has, more than quadrupled. So we've had many, starts and stops and shifts over the years in terms of our measurement-based care implementation and initiatives. So I'm happy to, share what I can about what we've learned and are continuing to learn in this process.
Super, thank you very much. And Dr. Perera, is there anything you'd like to add?
Thank you, Emma. Uh, I'll just add, I am employed by two chairs and I'm compensated by them. Um, Nothing major to add, just I'm happy to share a little bit more about sort of the two chairs model when we get into it so that you all can understand kind of the system I'm operating in as what are the constraints, what are the opportunities within that system when it comes to our MBC approach. So happy to share more there soon.
Super, thank you. And finally, Dr. Weisz, is there anything you'd like to add?
Yeah, I think most of us covered. I'll put the quick correction out here, and I think probably relevant to my bio is I'm not a doctor. I don't have a background in sort of behavioral health, substance use, or physical health care. Like my background came from business law, social enterprise, and I think maybe a couple of things that I'd share around hopefully the role I can play today is, we sort of get this interesting sidecar seat to organizations that are implementing measurement-based care, right? So we've supported, as mentioned before, like 500 plus behavioral health and substance use organizations with implementation of NBC. And I think along that journey, we have recognized sort of what works and what doesn't, what's important, what does good NBC look like, what do we have to think about around education and change management for clinicians. And so hopefully I get to, I would say, play a role of aggregating the perspective of our partners and what they've experienced, because I think I have a slightly different kind of background perspective than most on this call. I'd also add that it's nice to be on a panel with Caitlin, like Within Health is one of our partners, and I'm sure our team has learned a lot from Within Health, and hopefully vice versa in implementation of MBC. And then in terms of conflicts, I'm a sort of founder, shareholder, and an employee at Greenspace Health.
Super. Thank you so much. I think it just adds to, have a little bit more context. So thank you very much for those extensions to your introductions. So I think just to get started, I'm imagining we've got various levels of expertise on the call and the audience today. So just wondered from each of you, kind of what does defining the space, like what does measurement-based care mean to you? How do you understand that to mean? Actually you can decide between you who wants to get going.
I'm happy to kick us off, and I'll say something, and then let others fill in. I mean, I think one of this kind of gets into some of the challenges too. One of the biggest challenges that we've encountered has to do with sort of misunderstandings or misuse of the term, or just sort of the I guess very broad use of the term. And so one thing that we've really tried to focus on and try to communicate, both within our organization and then as we're doing things like this, is that when we're talking about measurement-based care, we're really talking about the clinical practice or clinical intervention aspects of it. So, people might be collecting measures for different purposes as somebody is engaged in treatment. They may be monitoring those measures. They may even be, incorporating them into program evaluation or even treatment plans for the patient. But I think the piece that really stands out to me is how that data is then used in sessions therapeutically with patients and those kinds of conversations that they have, and how that is really, I think, sort of the core mechanism of measurement-based care, at least as as we are sort of thinking about it.
I can add to that. Very similar over here. So just a quick context, Two Chairs is a outpatient mental health provider. Largely, our folks see us virtually about once a week for a variety of conditions, typically anxiety, depression, and some trauma-related disorders as well. So just so you have a little context on sort of how that works, we have several hundred clinicians who use our tools and platforms to support the care that they provide. So MBC is kind of built into those platforms. And I would agree completely with what Caitlin said. We really think about it as a clinical process. It's not just, did you use it or not? Like, did you complete this questionnaire or not? It's really, how does that information tell you something? Really, how are you making meaning around it to then inform the care that's being provided?
Yeah, I mean, I think that's well said from both of you. Often we are trying upfront in conversations to really help individuals and teams understand the distinction between measurement-based care from some other terms that often get kind of conflated with that. So assessment tools or outcome data. And yes, there's overlaps with both of those with measurement-based care, but I think Marissa and Caitlin said it well. Like, it's about the process and your ability to use it clinically to drive care. And there's a visual. I could pull it up on my screen. Actually, there's a visual that I kind of showed on a slide earlier today that I thought just like to the uninitiated was like a helpful way to describe like a kind of current state we're seeing with most organizations to where we're trying to go. And in a current state, depending on the sector, like particularly in the community-based sector, we are seeing the use of assessment tools. It's more often for reporting, and more often it's kind of pre and post. And we see a pretty low completion rate on a post measure, like often like 25% or worse when we're talking about a pre and post model that's really there for reporting and feels like data collection. It isn't really for that kind of clinician or client's benefit. And the shift that we're collectively trying to make with teams is to get to a place where you're measuring consistently throughout care. And that's helping to inform the conversation. And so not only are you getting, all these different data points on different factors potentially, but also you can change the trajectory of care. And I think that more than anything for me, what stands out is like the opportunity to change the trajectory of care. Certainly for, C-suite of many organizations, it also enables a deeper data set and, ability to use outcomes in different ways. But at its core, it's kind of the clinical impact. And I think Marissa and Caitlin both said that really well.
Thank you. That's really helpful. Yeah, as I said, we've got lots of different forms of expertise in the room, so really helpful just to define that from the start. And now just thinking about kind of linking it to this conference. So where do you see the role of digital mental health in both measurement-based care and kind of scaling it more broadly?
I can jump in with some of my thoughts here. Yeah, small question. No, I'm kidding. There's a lot here to kind of unpack, and I'm so curious to hear more too what Caitlin and Simon think on this. In a lot of ways, a lot of organizations are at what to me feels a lot like almost like step one of this process, which is like getting the buy-in, getting folks to just use it. And I think we're getting closer and closer to being at that spot to then kind of unlock the next level, which I see really as a lot of opportunity for the future, which is like even deeper personalization, but also potentially really like being able to predict a little bit more of what might be a most likely outcome or benefit for somebody early on to then be able to get preventative about it. And to Simon's point earlier, we really try to keep that perspective in mind as we're thinking about and building all of our MBC processes and philosophies and systems, which is that a lot of what the research shows about MBC, a lot of what the science shows is that it's quite helpful at identifying folks who might be getting off track. So that's a particular sort of use case, right? And so how are we really sort of making sure that it's geared to do that and then build opportunities for earlier intervention? So I think I sort of think about it as those two phases, and I think there's more and more transition into that second phase. But the first phase of just like getting the buy-in, getting people to use it, and the attitude sort of change, the change management around it is big and where a lot of folks are.
And I can just add to that piece, and I love what Marissa said about kind of that second stage and the personalization and using digital tools for predictive utility. I'm super excited to see, kind of where things go there. I think that first stage is a lot of where, we have focused the last couple years, and, getting that buy-in. And again, some of that is, culture shift and, clarification of terms and things like that, but also just thinking about how our digital tools can help really streamline processes and automate different processes so that it reduces administrative burden on clinicians. So then there is going to be more buy-in, right? So that doesn't feel like, oh, this is such a burdensome process. I have to do all these different things. That as much as possible, we can sort of leverage that technology to really integrate it into, their existing workflows and, have, these beautiful graphs that, really help them to utilize that information with patients. So I think, really considering kind of how technology can support that. And that's, sort of plug for Greenspace, sort of where we ended up sort of partnering with them was thinking about things that we were trying to build, but then also, where might these technologies already exist that we can really, use that to facilitate our processes and get that buy-in.
Yeah, you know, Marissa and Caitlin both spoke to like the current state well, like step one of, I would think of it as like how do you bring down clinician effort and bring up clinician value, right? Because your goal from the start is how do you get the clinician adoption and buy-in and change management, as was said. And so, coming from the technology vendor side, I kind of think of technology and sort of digital mental health as table stakes to be able to get there, like to expect providers or clinicians to manually do this with either pen and paper or manually typing assessment responses into their EHR with no visualization during session is sort of unrealistic to expect that change to happen. I think table stakes is technology and it is good integration into your workflows, right? So Caitlin, within there's an integration within the EHR, kind of depends on the EHR system, whether it's homegrown or another technology provider. Like there's almost always an option to find an integrated solution to support that. For me, like I actually get really excited about where we're going, and I know Caitlin and Marissa didn't touch so much on that, so maybe I'll throw out a few ideas or thoughts around how Greenspace is thinking about this, right? So you've sort of gotten to this place where now we can support a successful implementation of measurement-based care, and bring down clinician effort, bring up clinician value. I think there's now an opportunity as the data sets that exist on measurement-based care grow and our understanding of measurement-based care evolves. There's an opportunity to use this data to drive more insight and more value ultimately for the clinician to affect care. And that's, from our perspective, a lot of where we're going is, we now have a data set of 5 million plus completed assessments. It's likely the largest data set on measurement-based care in North America. And that lets us do a few things, right? So it lets you, use that data, bring in new technology like AI and ML models, and start to predict, as Marissa said, like whether this is a client where there's a high likelihood of early dropout based on the patterns in symptoms and responses, or predict expected treatment response, or set benchmarks not at an aggregate level, but all the way down to a client level in terms of what sort of on track, at risk, and off track look like. And so I think there's more and more opportunity with technology moving forward to go beyond where we are today in terms of the value to the clinician, right? Can we give more decision support, more insight into what's happening in care? And so that's where I get really excited, because the research already points to a massive impact that MPC can have on quality of care and outcomes. But if we can take that 1, 2, 3 steps further with technology, that gets like particularly exciting on the client impact that's possible.
Yeah, that's super. I don't know if Dr. Perera, Dr. Shepherd, if there's anything you wanted to add to that about kind of where you see the future of the work you're doing, where with particularly with digital interventions and digital mental health, how that's going to play a role.
No, I'm just excited. I'm excited to see those kinds of capabilities come to fruition. And I think that will, as Simon was saying, further reduce the clinician burden and increase the clinician value. And I think really allow clinicians to do the work that they like to do and that they are really skilled at doing by having these kinds of supports built in. And I think that's a really important piece that I know we try to clarify a lot with our clinicians, that none of this, especially as we get into AI and things like that, that people might be, have some skepticism around. None of it is meant to like take away their jobs or, reduce their clinical judgment, but really meant to just further support them. And so I'm excited to see those kinds of use cases, come about and really support our clinicians even more.
Yeah, and I'll just add that our thinking is very aligned with what Simon had described, which is as we get closer and closer to a place where we do have a lot of data and ability to kind of really understand that data, its patterns, how can we now use that to create information to provide insights to support decision making for providers? And that could be around a number of things based on the nature of that data, right? It could be, and what's also effective for a clinician to have information on. So certainly, is this person kind of falling off track or on track for what we might expect? Maybe like I think about things like if they have a certain symptom profile, we know that depression, for example, has a couple different symptom profiles. How do we think about sort of the treatments that are most effective at targeting that particular constellation of symptoms, and how are we sort of making it easy for clinicians to think about that when that's what the data is demonstrating? So I think there's a lot of opportunity like that. One thing that I also think about that I don't have a formulated thought around, but that I could see as a future direction is like passive, or what is the right word? Like wearables.
Passive data.
Yeah, exactly. Passive data and how that might begin to be used as another source. I think right now, a lot of like sort of what payers and insurance plans like, value and are used to is why we've landed on some of the things that a lot of healthcare companies use. But there is something interesting to think about how that like wearable kind of passive data might get incorporated into the process.
Yeah, absolutely. Thank you so much. And just thinking about some of the, we touched on it already about some of the importance of buy-in and the flip side to that, what do you see as some of the common challenges, particularly around scaling measurement-based care?
I'm happy to share maybe a few categories, and then I'll transparently ask Caitlin to say what have been the hardest things about implementing sort of Greenspace and NBC it within health. But I think in terms of like scaling measurement-based care, like first and foremost, it really is about the clinician experience and the clinician buy into that process. And to make the clinician experience engaging and easy to incorporate into a day that doesn't have a lot of free time, I think organizations have to be really thoughtful about workflow, right? So an ideal state is based on the steps that are already happening within the EHR system. Like we are adding this client to this, PHP program, and they have a presenting issue of this, and here's the modality or evidence-based practice. Like based on these data fields, then automatically in the background, we're assigning a package of assessments that the organization has sort of set as our baseline for this care pathway and this client population. And so ideally, you've automated a lot of that workflow so there aren't extra steps for the clinician to get this started. Then ideally, you're engaging the client directly in completing these measures, whether that's remotely by email or text or on a kind of tablet in the waiting room or via another method. And then like ultimately the role of the clinician is not to go administer measurement-based care or chase clients to complete measures or complete measures in session. Ideally, the role is to review results with the client. And so I think if you can get the workflows right and reduce effort, you give yourself a way better chance of success. Then I think the fun part is how do we engage clinicians and make this valuable? So what education are we putting in place to help support clinicians in understanding the value and understand how to actually bring this into care and make it useful? What structures are we putting in place to make this more valuable? So do we have a model of clinical supervision that's now going to bring the NBC results into conversation? Do we have, maybe a kind of role-playing exercises between clinicians and peers? Do we have storytelling where peers are kind of talking about cases where measurement-based care is valuable? Like what levers do you have to build that buy-in and kind of make the process more useful? So I'd say like a lot of implementation and success focuses on the clinician. Where we see the most challenges with partner organizations and getting this off the ground is when we don't have a clean workflow that makes it really easy for the clinician. I'd say B, if we don't say sometimes you have like C-suite buy-in to bring something in, but maybe you don't have buy-in from like that program manager or clinical lead for a a particular program or area of the organization. Like that can be challenging because then all the messaging and communication around the clinical value and all the work you want to do about clinical supervision and case consults and that like kind of falls away. And so being like the end of the day, it comes back to the clinician. So being able to set them up for success is everything you kind of have to work around in the first phases of implementing MBC.
Thank you
And
so much.
Caitlin, now I'll ask, like, you got the other side of that from the Greenspace team, and I wasn't directly involved in implementation of these conversations. So I'm curious, what worked, what didn't.
Yeah, no, I think all of that is very true. And I mean, I would say probably one of the biggest challenges for implementation with us, which Greenspace has done an amazing job of supporting, is that, we already had so many processes in place to begin with. And also we have both a partial hospitalization program and an intensive outpatient program. And so, I think kind of the combination of already having kind of existing systems in place, that we were then needing to kind of get that clinician buy-in and sort of understanding of like why we might need to shift things. But I think ultimately what we found was most helpful was going to those clinicians directly and doing like focus groups and getting feedback from them of, so many things, like what is their understanding of measurement-based care and what is working and what isn't working. And, I think we were kind of initially starting more from that leadership position of, okay, what are our implementation plans? But then so many of us are not in the day-to-day seeing why this might work or why this wouldn't work. And so I think really engaging those clinicians in those direct conversations and giving them a place to share their concerns and their challenges and their thoughts has been really helpful. And I mean, they've had fantastic ideas of different resources. I mean, that's been a huge thing for us, not only the supervision piece and making sure we have that, as well as, times and ways that people can easily reach those of us that have this expertise and are involved in the implementation, but also just having so many resources available, and, continuing to build that resource library for folks, I think has really helped with that implementation. And, just making sure all of that is available. I do actually see a question in the chat as well that is actually very relevant to one of the other challenges I think we've encountered with scalability and implementation, which is this piece about personalization, right? As we've grown, I'm sure other organizations, we are trying to reach, an increasingly diverse population. And so if you have like that standard battery of measures that you're using, the PHQ-9 or the GAD-7, which we do use among others, those may not be as relevant, right, for everybody, depending on diagnosis or age or race or gender and other factors. So I don't have answers to that, but that's definitely a big piece that I know has been a challenge for us and on our radar, and working with, Greenspace to try to figure out, what additional measures we can build in and how can there be ways, whether it's sort of an automatic trigger, like somebody has this diagnosis or somebody is in this age group, that automatically they get sort of funneled into this pathway, or other sorts of indicators that might come up along the way that we might then send different measures, or maybe we're using some of the same measures, but we might need to use different criteria for interpreting them, or just have more direct conversations, I think, with our patients about the limitations of some of the measures and how we may be using them in treatment as well. So I really liked that question and want to make sure to touch on that too.
Yeah, this is great. I have a couple different thoughts rolling around. Just to sort of address the really like insightful question in the chat. It is a challenge. I do believe, this is like almost an inherent tension in a way of a large organization, scalable kind of standard practice and technology, and also personalized care. And so I do think our systems are getting closer and closer to these spaces that make that like really personalized battery of assessments easier to select and go off of. And the way that and this is certainly a challenge we have, experienced as well, because we do serve a very diverse population of clients with varying diagnoses and have a large population of clinicians who treat in very different ways also. And so the way that we've approached this to date is really trying to build as much of a sort of like global set of measures to reach as many, be as applicable to as many people as possible, knowing it's not going to be accurate, like the most accurate set for every single client, but that it is likely to be an accurate enough set for more clients than not, and then begin to kind of really understand where are the next like pockets of sort of more specialized concerns that we might want to bring into our system and enable that flexibility to sort of tack that on or remove that off. So these are the kinds of challenges we grapple with. And part of that is really like the technology design too, right? It's how do you really think through, you've sort of got a standard, more or less like a standard way of operating, how do you easily bring in these flexible features that also don't lose that like global set? So these are things that we are certainly thinking through and have faced. I'll also add a couple things to the scalability question. So when I think about scalability, I think about probably 3 different areas, a couple of which were already raised by Simon and Caitlin, and I think Simon highlighted the workflow bit, and that's huge. This is not like typical experience for most clinicians at this point in time. I think this might change over the next couple of decades, but right now this can feel like quite a disruption to the workflow of like sitting with a client. And then like you're suddenly, it can feel like a real art, right? Like sitting, having this connection with someone, and then it can feel like, well, this is just data. It's not, it's minimizing this person's experience. And so there's like something about that experience that is really important to try to support and get on the same page to really get that flowing. And the technology is critical, I think, to being part of that. I think Simon said like, this is kind of table stakes, like we need the technology to support this. And I completely agree. And as part of that, I think about interoperability, which is basically like, how are we getting the right data at the right time to the right person? So it's all part of the workflow. Another thing that I think about, which I think you both touched on, I think about it a little bit as like that clinician buy-in or the provider buy-in. And I actually think that for some folks, this goes quite deep into like, what is my identity as a provider? And we have observed this at Two Chairs, where because we do have providers who practice in very different ways, very different therapy styles, some find it more natural to bring this process into their care, and others find it to be a real kind of like questioning that brings out maybe defensiveness in them as to, well, why do I need this to tell me what to do? Like, I've got my experience, I've got my training, I've got my judgment, and this is like questioning that. So I think that that's also a really key piece that is not a small thing to resolve and requires some like careful attention. And then finally, I think about patient trust. We know that most therapy clients or therapy patients are not used to this data probably being asked of them. And especially when we know majority of providers are not using it themselves and that it's not typically part of like standard training programs, there's some risks there in like, why are you asking me to complete this? What are you going to do with this information? Why do I need to do it? So I think it's important to really have the client or patient understand why this is part of the process and have that buy-in also.
Yeah, that's super interesting. Actually, I was linking into one of my other questions, which was, have you done any work kind of investigating what patients themselves think about measurement-based care, what they understand this to mean? As obviously you've done some work with providers. So yeah, just wondering if you could talk about any work you've done with patients around this.
Yeah, I can share some trends that we are noticing. We're suspecting that we're seeing a bit of a trend where when a provider is like bought in to MBC and they understand the clinical sort of process value of it, their clients are more bought in. And that when a provider, including these providers who find it to potentially be at odds with how they prefer to practice, that those clients tend to have like an experience of, I don't really get why we're doing this, or a more negative experience.
That's interesting.
Yeah, I would say like Marissa, we see the same thing in our data set, and it's essentially a very strong correlation, if not a direct correlation, between clinician review of a client's results and like their visualization of progress and client completion of assessments. And so ultimately what that tells me is if a client's being asked to complete measures and then they're going into session and no one's talking about those measures and they don't understand why they're completing them, they're going to stop completing them. And so, we talked a lot about value to the clinic, like effort and value for the clinician. I think it's the same thing for the client. And so for clinicians that are using this and engaging with it and bringing it into conversation, clients understand why and see the value. And interestingly, we'll see for remote assessment completion consistently across clients, we'll see really high engagement to start, and it's depending on how the clinician engages, that will fall off or continue. So like absolutely clinician engagement drives client engagement more than any other factor.
I would say we've seen, similar that piece around the clinician buy-in, and then the patient real, understanding of it and really seeing how it is being utilized and supporting their care. And we've definitely seen that the more that we, clarify that and set that expectation up front, and, make sure that we're actually having the clinicians have an explicit like orientation to MBC, talk with the patients so that they know from the beginning what the data is for. And again, that allays some maybe concerns that they have too, but also it's just very clear to them why they're completing these measures. I know we encounter a lot of folks in our program who have completed similar measures elsewhere, but usually it's been for research purposes or maybe for insurance or accreditation, for some other purpose, and not actually, being directly used to support them in their care. And so the more that we've, very clearly set that expectation up front, I think the more that we've seen patients as well, really engaged and bought in.
Yeah, thank you. Very insightful. And I guess linked to that as well, are there kind of particular lessons you've learned and any surprises in kind of your journey from doing all of this work that you think would be helpful for maybe the next generation of, clinicians or people, researchers who are working in this field, that you think should be investigated further?
I have so many things, but I'll start with one and then let others jump in. I think one of the biggest sort of lessons learned for us was the benefit or importance of starting small. I think when we were first starting to really kind of think about refining our processes and further build out our MBC protocols, we put together this huge list of all these different measures that we wanted to be able to utilize to make sure that we're tapping into like everything that we could think of for every different, patient population that we work with, and had like this beautiful spreadsheet of, everything that we wanted to include. And then ultimately, when we went to actually go start implementing this, realized, well, that's certainly we can't do that right this moment. And that what was really most important was to identify like what are the measures that are core to our program. Let's get those going, and then have sort of a prioritization and then further rollout of some of the other additional measures that we needed. And again, I think really involving the clinicians, but also sometimes the patients in that, or just sort of hearing what feedback we were getting from patients around what they felt was missing. Just for example, for us, so again, with eating disorders, we have some patients who have ARFID, which is a very different eating disorder presentation than what you might typically think of. And so some of the measures that we have just don't really seem to apply. And so we wanted to make sure to prioritize that. But I think in sort of looking back, just sort of from the beginning, being more I guess, accepting of the fact that this was going to be a slow process, and that's okay, and really trying to make sure that we were prioritizing and refining our protocols as much as we could before trying to do too much.
Yeah, I think that's an important message. Things take longer than you expect, quality over quantity. Yeah, I think that's an important one. Marisa and Simon, I don't know if there's anything you wanted to add about lessons learned and surprises that would be helpful to kind of impart that wisdom to others on the call.
Yeah, I can add something because I think in some ways we have actually taken like a quite slow, thoughtful, concerted approach in some like instances. We have a bit of a muscle to like really always pilot or beta test something for a period of time. And so even with validated measures, we're often doing this. And I think what my biggest takeaway is really that like clinician support. What I find most helpful from sort of these beta tests that we run on adding a new measure or something like that with a couple of clinicians is certainly, yes, like, okay, how does this feel? Does it feel relevant? But also what's really special and unique and scalable about the learnings from that is those clinicians can share with us like, okay, you know what, this bit actually really didn't land as well with me as to like how it translates into my clinical practice. Oh, this bit actually did land. And so now we can take those like learnings to support the training of the actual content. So that really has been a model that has worked for us well. I think the flip side of that is like, for example, if we have a measure that folks have been really wanting that we think we have like a notable, need for, we there's like a risk benefit question of do we just roll it out because there's like a gold standard enough version, or do we really take a little bit of time, slow down, test this? And that means there's like folks who want that measure earlier who like are, really voicing that they want it. So it's a bit of a push pull there, but we have found that really leaning into what is your experience testing this, using this, even if we assume, and usually these are not measures that are brand new to providers, right? Oftentimes they've heard of them, they're familiar, but they were often, in our experience, they haven't often been trained on like, how do you actually use this though to get information and insights? And that's where slowing down to do things like pilots and betas has been really helpful so we can scale that information.
Great. I'll try and add a quick thought and then maybe tie it in a little bit. Kiefer had a question in the chat that that we can jump to. So like 100% echo what Caitlin and Marissa are saying. I think generally, if somebody is going to ask me for advice on implementing measurement-based care, my advice will be to start. There will be a lot of learnings and adjustments to workflow and measures and education in your approach over time. And one of the, I think, pieces that folks don't understand is like don't always appreciate is like the benefit of like the continuous improvement, both in terms of implementation of measurement-based care, right? If you start small, you build champions, you understand what works on implementation, you understand what workflows work, like you can accelerate that adoption pretty quickly across an organization. But also in terms of the data you're getting at an aggregate level on outcomes and your ability to use that data to adjust programming has kind of continuing and exponential like compounding effects. And so, Kiefer asked the question of like how much tracking is being done on the intervention, to say that MBC works is not necessarily convincing without the associations to the intervention. So broad strokes, I'd say across our partners, like many are tracking kind of outcomes against intervention, right? Like that's when you get to the outcome data, that's obviously really important is they want to be able to see, what's the impact of this intervention. They're also tracking other things like, client demographics or other factors because they want to break down and understand like, is there a health disparity here? Are we seeing a certain client population is not seeing the same results as others with the same intervention? And should we adjust for that client population? Or maybe this intervention within this program is not seeing much impact with this profile of client. So let's not do this intervention with this profile of client. And so that's the I'd say the use case today for MBC versus like bringing intervention data or other data into the measurement-based care outcome data. The underlying question, Kiefer, of like, how do we know that measurement-based care works or is valuable? Like, there's a ton of research on the concept. I won't speak to the like all the studies today. I think just in the Greenspace practical experience, there's two ways that there's kind of two use cases where we have a control where we can see that impact, right? So one is we work with an organization that is already doing measurement in some way, but it's being done in a reporting mechanism with pre and post and not with continuous measurement throughout care. And very consistently, once we see an organization move to consistent measurement throughout care, we see better outcomes. And it is not, like I'll say, it's not because we've digitized the scale. It has nothing to do with the digitization. I think it has everything to do with the clinical process, right? A clinician is now using this information consistently in care and is guiding their treatment planning and is guiding the conversation and is really bringing the client voice into care. The other, and I think more interesting thing that we see is that year over year, organizations are seeing better outcomes. And I'd say the UK has maybe the best case study on measurement-based care implementation in their National Health Service. And they initially implemented like a broad-based like measurement-based care implementation across a program called Talking Therapy, but really it was a publicly funded CBT program they rolled out nationally in 2008. And they made MBC central to it. In their first year, their reliable recovery rate was 38%. Over the next 10 years, it went up to 48% and improved pretty linearly. And today is about 52%. They publish it transparently, and there's data at each site in terms of what outcomes are. It is the story you hear there and the research you see come out of there is all about how they're able to use that data to continuously improve. And so we know from the research that implementing MBC is going to drive better outcomes. What we don't often talk enough about is the benefit of A, starting sooner, but B, what we can then do with this data to continue to improve care. And so I sort of think of measurement-based care as a foundation for understanding what's working and continuous improvement within an organization. And like, yes, absolutely, you need that intervention data to help inform the decisions you're making with the aggregate outcome data.
Thank you so much. Yeah, I hopefully that answered your question, Kiefer. I'm conscious of time. I realize we're nearly at the end of the session. So just to finish, is there anything else that any of the three panelists would just like to add in sort of 1 or 2 sentences before we close the call today?
I was just going to add that I loved this. Oh, sorry. I love this question from Kiefer and Simon's response. And yes, there is some additional research. I know there's research been done, specifically looking at like when you show the patient the graph and actually engage with them versus you don't, and seeing some better outcomes there. But I think ultimately we don't know for sure like what is the mechanism. I know there's also some work around the measurement-based care, increasing therapeutic alliance, and then maybe that's sort of the key piece of it. So I think it's a great question, and we sort of see that implementing it is associated with better outcomes. But I would love to continue to explore further, like what are the actual mechanisms behind that, so that we can continue to really hone those interventions.
Yeah, I'll add it quickly. Same thing. I agree with all of this. Certainly, this is an area where research is actively being done to like really elucidate what might be some of the mechanisms that are scientifically backed here. I'll add quickly that things that we really try to build into our tooling and how we think about this is not just how does the clinician interact with MBC, but also just what was highlighted by Caitlin, like the client experience of MBC. So we share visuals with the client to bring them into the process and make this collaborative. And also before getting to outcomes, like also encouraging in our tooling reflect like engagement with the data, basically. So this is what the data looks like. Does this feel like it represents your client? Why or why not? So like really kind of prompting for that in the tooling.
Amazing. Thank you so much. Really enjoyed the discussion today. I learned a lot as well. I hope you enjoyed being part of the panel and learning from each other too. So yeah, just want to say thank you so much again for your time. Thanks to everyone for attending in the audience. And I hope you enjoy the rest of the conference.
Thanks, everyone.
Thanks, everyone.
Bye.